So it is rare that I will get a question specifically about insurance, but I can think of a number of cases that certainly touch on reimbursement issues. I'll give you a couple of examples. One example I had with a reimbursement issue, or the most common one, I've had a number of these, would be, what do we do with a patient who doesn't have a reimbursement source? So I can think of one patient, for instance, who needed dialysis and was an undocumented alien and in Virginia was not eligible for public assistance, although other states this person would be. And the hospital dialyzed this person. I mean, they were driving through town, right? Crashed. Right? We bring them in, we dialyze them, they're stable now, they don't need inpatient hospitalization, they will need dialysis again within a few days. The outpatient center says, well, we won't take anyone without insurance, so they're not coming through our doors. And they're at least 3 to 5 days away from home with a sketchy automobile that may not make it. And the hospital's thinking, do we have to keep them in the hospital? Do we have to discharge them? Who's going to eat the cost of this? I get those consults all the time. Someone without reimbursement, what is the hospital's responsibility? That comes up. The most interesting insurance case I ever had was a woman who was receiving services from a community services board. And for those of you who don't know about CSBs, they're the community-based providers of, in this case, mental health services. She was eligible for Medicare Part D, but absolutely refused to enroll. The CSB had a policy that said, we will not give you free or even reduced cost meds if you are eligible for an alternative funding source. The client said, I've been getting free meds from you for years. The fact that now there's this newfangled thing called Medicare Part D doesn't really excite me. I just assume get free meds from you moving forward. We worked with that person for a year. The open enrollment period comes, and again she refuses to sign up for Medicare Part D. Big ethics consult. Can we cut her off from our supply of meds? We've been feeding her out of the med sample closet. Is it ethical or not ethical to basically say it's your choice that you didn't sign up for Medicare Part D, therefore you deal with the consequences? And then throw on top of that an overlay of, paranoid psychosis, where she thinks the government is going to do awful things with her information, and that's why she doesn't want to sign up for Medicare Part D. How do we manage the circumstances? So these things do come up. Maybe what we ought to do, so you can see how all this works, is I'm going to start moving through some of the material, and then you'll ask your questions as we go, and if you have any left over at the end, we can certainly talk about them then. But I want to start with one illustrative case to show you the kind of thing. This is an old case. This is one of the first cases that I dealt with ages and ages and ages ago, and the medicine has changed a little bit over the years, but not enough that this is no longer a good teaching case. In fact, this is my favorite teaching case because it will demonstrate to you all of the points that we need to demonstrate in practical clinical ethics education. So here's the opening slide, sort of the history on this person. The story involves Ms. A. She's a 24-year-old black female, unmarried with 2 children, no private insurance. So that's her social history. She comes into the emergency department complaining of a headache, but she denies history of any serious illness. So she comes in looking pretty good, walking under her own power. She's able to converse. She's oriented to time, place, and person. So she's looking pretty solid. And she's holding the back of her head and says, I had these weird headaches. I feel sort of dizzy and I have these weird headaches. The attending in the ED says, well, do you have a history of neurological problems? What's going on? No, healthy as not. It's just weird headaches. So the physician decides to admit her for a possible workup or for workup of a possible seizure disorder. Maybe she's having little seizures. We got to get neuro to take a look at her. We'll see what's what. Well, as soon as we take responsibility for her, and you clinicians out there will understand how scary this can be. You don't even have a good history and physical on her, but your name is now on her chart. And bam! She crashes instantly. She is unconscious. Her vital signs are in the basement. This is an extraordinarily sick woman, and you don't know what's going on. Now, this is a story that starts from bad and gets continually worse. Right? So, her condition deteriorates very rapidly once she's in the hospital, before we've even had a chance for anyone to look at her. And we don't know what's going on. So we're going to get some blood work done. We're going to get some rapid blood work done. We're going to find out everything we can find out. Well, it turns out that she is HIV positive. More than just being HIV positive, Ms. A has a T-cell count of 4. Now we'll see how honest everyone is. Who does not know what a T-cell count of 4 means? Excellent. All right, see, this is exactly what you're going to have to learn if you want to go into clinical ethics. T cells, and they don't have to get into the complicated facts because there are different kinds of T cells and such. But basically, when I get your T cell count, I'm testing the strength of your immune system. All right? So a normal adult human being has a T cell count in the thousands. If you are HIV positive, which Miss A is, and your T cell count drops below 250, you are considered to have an active case of AIDS, not just a pre-AIDS complex, not just HIV positive, but actually a full-blown case of AIDS if your T cell count drops below 250. You all understand that HIV is an immune deficiency disease, right? And so what's happening is your immune system is being eroded, and we can measure, by looking for certain types of cells, we can measure the strength of your immune system. Normally in the thousands, anything below 250, if you're HIV positive, you've got AIDS, right? She has a T cell count of 4. She basically has no immune system left. When she said, I've never been sick a day in my life, healthy as an ox, there are only 3 possibilities. 1, she's lying. Because for your immune system to be that debilitated and you not to have already experienced some opportunistic infection would be extraordinarily rare. It's possible, which leads to number 2. This is the weirdest progression of an AIDS case we've ever seen. Somehow she managed to live in a bubble while her T cell count got to 4, and now she's sick for the first time. Third possibility, she's having some sort of dissociative episode. She's in deep denial and just psychiatrically is incapable of recognizing the state of her own illness. But she says, I was healthy as an ox. She's HIV positive, T cell count of 4. The story gets worse. She doesn't just have a T cell count of 4, but we do an LP, a lumbar puncture. That means we stick a little needle in her and draw off some cerebral spinal fluid, a spinal tap, okay? And we find out that she's growing out a cryptococcal meningitis. Now, cryptococcal meningitis is a very tough bug to kill, even in an otherwise healthy patient. If any of us, normally healthy, fully functioning immune system gets a cryptococcal meningitis, it's very serious. We're using high-powered antibiotics. There's still no guarantee that you're going to make it out. You put cryptococcal meningitis into a woman with a T cell count of 4, I don't want to sound like Tony Soprano, but forget about it. She is not clearing this infection. Now, we're doing a little better now than we used to do 10 years ago. But this is an extraordinarily serious situation. It gets worse. We get neuro involved. A neurologist comes in to do an exam, and the neurologist says she has irrevocable and serious brain damage, secondary to cryptococcal meningitis. When she said she had those headaches and that dizziness, that was her brain boiling. She is now seriously neurologically impaired. And the neurologist says, I believe that she's probably in a PVS, a persistent vegetative state. Persistent vegetative state is a state of permanent unconsciousness. It is not brain dead. You still have brain function, but your awareness is no longer intact. You are permanently unconscious, unable. The legal definition contemplates a person who suffers a neurological insult and as a result exhibits no learned interaction with the environment. You could still have sleep-wake cycles, so you can open your eyes, shut your eyes. You could have involuntary creative motions. You might even respond to a deep sternum rub. You could have deep stimulus response, but you are completely unaware. You are unconscious. Notice, however, we say probable. So we press the neurologist on this. Why do you say probable? Why don't you just tell me whether or not she's in a PVS? Answer? P in PVS stands for persistent. So according to the diagnostic criteria, which neurologists follow, they would have to be able to say that there has been no neurological improvement for a period of 30 days. We can only make a provisional diagnosis until a span of time passes and we can assess the baseline and whether or not there's any neurological improvement. So the neurologist says, look, I have seen a gazillion cases like this. I'm telling you, this is as good as it gets. She's never going to wake up. She's in a PVS. But I can't actually say that because not enough time has gone by. So I'll tell you what. This is the neurologist talking. You believe in miracles? I'll give you your miracle. First of all, it's a 1 in a 10 million chance. It's a 1 in a 10 million chance. But if I'm wrong and you get your miracle, what are you going to get? You're going to get a woman who's not in a PVS. She will wake up. She will be non-ambulatory, non-communicative. She will not recognize friends or family, and she will lie in a nursing home bed for some short period of time until the cryptococcal meningitis resurges and kills her. That's your miracle. I think you got a 1 in 10 million chance that's even going to happen, but that's what your miracle looks like. She is not going to wake up, stand up, dance a jig, and go home to full function. Physician wants to avoid extraordinary care, including intubation. If you don't know medical terms, you should ask about them. Intubation means placing you on a ventilator, that tube that goes down your throat and put you on a breathing machine. So the doctor wants to avoid all extraordinary care, including intubation. Family indicates that all life-saving measures should be utilized no matter what. They don't even want to talk about code status. They don't want to talk about what we're going to do if her heart stops beating or she stops breathing. Although they are willing to say if she needs to be intubated, intubate her. As long as she's got a heartbeat, keep it going. She's now experiencing early signs of respiratory insufficiency, heading towards air hunger. We need to make a decision: do we or do we not intubate? And that's when, well, in the old days, my pager would go off. Now it's just my cell phone. So this is an ethics consult. Show of hands. How many people think, you've got to be kidding me? We're going to place a woman with HIV, T-cell count of 4, cryptococcal meningitis, severe neurological damage on a ventilator? That's bad medicine. Don't do it. How many people think, yeah, this is crazy? This woman does not belong in a vent. Okay? How many people say, family wants a vent, family gets a vent, we're done. All right, we've split the room. How many abstain from the voting? Aha, those are the smart ones. How many refuse to raise your hand no matter what I ask? No, don't get one of those. Abstainers. Why are you abstaining? What do you need to know in order to make a decision? We're running out of time here. Ms. A is an air hunger. You can't just study this for a semester. We need an answer and we need it now. So what do you need to know that you don't know?
Is the family willing to pay for it? Can they pay for it?
Oh, what's your name?
Aaron Cleanfield?
I just need first names. That's all right.
Aaron.
Aaron. So Aaron's position is this. Rich people deserve to get ventilators. Poor people should die.
No, that's not quite my position.
All right. What is your position?
My position is basically the length of time that she would be on the ventilator depends on how long they can keep her on it.
Well, I got news for you. If her heart rate's going fine, we can keep her on a vent for an extended period. Now, the key question here is going to be the cryptococcal meningitis and whether or not she has any other sort of autonomic failures. But her breathing is going to be the first thing to go. That's normal, right? But I've seen cases where people who are ventilator dependent and in a PVS, their hearts hold up for years. Karen Ann Quinlan, who was the test case back in 1976, was on a ventilator for 12 years. Actually, she wasn't. They took her off the vent and weaned her off successfully, but she ended up living for more than a decade before she died. So we don't have any indication that there's cardiac involvement here. And look, we can fix just about everything. We'll put in a pacemaker, we'll dialyze her if she goes into renal failure. We'll put in a PEG tube for enteral feeding. That is a feeding tube we stick in the abdomen so we can keep her nourished. You want a farm vegetable, we got one for you. Should we do it?
Probably not, no.
Probably not. All right, we have another response.
Does she have an advanced directive?
Excellent question. Exactly the right question we needed to ask first would be, do we have any value history on the patient? Would she want to be kept alive or not? Did she have an advance directive that instructs us about what she would want done if, in fact, she were in a situation where she's terminally ill or in a persistent vegetative state and unable to make her own healthcare decisions? Well, of course, you know better than to ask that question. The answer is no. A very low percentage of the population, unfortunately, actually give this enough thought. And Ms. A was already in denial before she came in. Right? She didn't come in saying, look, I'm struggling with this illness, and I really want to plot out my future, and there are certain things I want and certain things I would not want, so let's have a meaningful conversation about this. She comes in unassigned, no history. Her friends and family don't even know that she's HIV positive. And she's already got a T-cell count of 4 and cryptococcal meningitis before she presents. Unfortunately, no advance directive. So then the question would be, in the absence of an advance directive, what happens next? Yeah.
So I'm in the club that thinks that you should give her the medical care she needs for now, because it seems like would have so much to deal with